Greetings, everyone, from the Livongo office today, where it's quite odd to not have a lot of folks, but as many of you, the homes are crazy, so we'll focus here. I'm excited to have both of my two debaters on stage. The rules of the game are there are no rules, right? Keep it clean, keep it fun. I reserve the right to cut you off at any point in time, and really looking for a healthy debate in what I believe and we at Seven Wire believe is truly a transformative time in our lives as we think about the future of insurance and really how it can be reimagined. And so let's kick it off today. The first question is, how did we get here? Why is health insurance so complicated? And is there someone to blame? And maybe Michael, let's start with you.
Sure. Good afternoon, everyone. Hopefully everyone can hear me just fine. So thanks, Alyssa and Shawn, for kind of volunteering to be in the pit here. We'll give it a good tumble this afternoon. So the question about health insurance and how we got here is actually a fairly convoluted history of health insurance in America. And the funny fact of how U.S. healthcare differs from most other nations around the world is that over 50% of people in America get their health insurance from their employer. So unlike many other nations that have nationalized or state-sponsored healthcare systems, we get it from our jobs, and there's a lot of different ways that happens. Now, it's not the total population. Our Uncle Sam kicks in and covers many folks, whether through the Medicare programs, the Medicaid programs, or through the military and the VA. And then there's also the opportunity for individuals to kind of purchase insurance on their own. But the fact of the matter is, and the way we view it here at OMERS Ventures, we're largely living in an employer-sponsored health insurance world, and to a lesser degree, a government kind of sponsored world. I don't want to get into whether that's a good thing or bad thing. We can have a whole another debate on that. But as a result of employer-sponsored healthcare, it leads to a lot of inefficiencies, or also in venture parlance, a lot of opportunities. So that's where I've personally spent a lot of my time as a venture investor. Most of my investments have been against kind of employer health-centric themes. And at OMERS Ventures, we continue that trend on that front.
Shawn, why are we here? Who's to blame?
Sure. You can judge, I guess, who's to blame. My thought in most things is we usually end up with what we intended or designed for. And I think that is exactly what has happened here. You get what you designed for. And I'll actually start with where we go and receive care. If you just think about the last time you visited a clinic or a hospital or a pharmacy, that's how they are constructed as clinics, and you come there to see a doctor. They're constructed as hospital. When you need a bed and you need to stay a while, you come to the hospital. And we just get more clinics and more hospitals built. And because of the way that was designed, we built hospitals and clinics long ago and have keep building them. Then I would say insurance has largely just followed that design pattern of, when it comes to insurance, what do we need to cover? Well, we cover clinic-based services, we cover hospital-based services, we cover picking up scripts. So when you cover those things, you naturally get consumption of more scripts, you get consumption of more office visits, and you get consumption of more hospitalizations. So I believe we're where we're at. It's because that's how we deliberately designed, architected, and built for exactly what we have, which is we have a bunch of consumption of hospitals, doctors, and drugs.
It's interesting, Shawn. I get this question a lot, and I imagine those in healthcare do. How much time as consumers should we reasonably spend trying to understand health insurance? What's appropriate?
Yeah, sure. So my answer is that we spent 20 years trying to figure out deductibles and coinsurance. and thinking that no matter how much someone spends in the next 2 months in their annual enrollment period, we spent 20 years trying to figure it out. And depending on what research you look at, low single digits of Americans actually understand copays, coinsurance, out-of-pocket max, and deductibles. So they've spent 20 years. So I would say, I think we reached the limit long ago, and the answer long ago, which is you couldn't spend enough time, because it's clear after 20 years, people don't understand it. So that's where Bind has a different point of view, which is if we're going to get people to understand it, which we believe is actually the starting point, in order to have change, we believe the best agent of change are people themselves. In order to get them to become agents of change, they have to understand what they can use to make the change. They have to understand their coverage. They have to understand within the coverage, what are my options for the various conditions I have? Is it a doctor? Is it a virtual visit? And when you don't understand the coverage, you really can't do anything. You really are essentially rendered helpless. And so you end up just feeding back into the design, which I described, which is I just have to make an appointment and go talk to a doctor, because I don't really know what else I can do. And I don't know I don't know how much I have to pay, but that's all that's available. So the question about how much time can realistically expect them to spend, I would say if they have designs that look like the designs they've had for the last 20 years, I would not expect them to spend a lot of time, because they've been there, done that, and they know they can understand it. So why would I waste my time?
Michael, what do you think? Should people be spending time here? Can they actually be an agent of change? If so, what should they do?
Yeah, I'm going to call an audible and actually ask to go back to the prior question for a second, and then kind of come back to this one, because I want to pick up.
Let me check my debate rules. Okay, I'll allow it.
I think what Shawn was talking about the state of insurance really gets, so we're in a fee-for-service world, right? And all of insurance is fundamentally about kind of economics, payments, reimbursement, money flows, and risk management. I thought for a minute, since he is the insurance guy, he was going to pin the blame on the providers and the docs, but he actually didn't go there. So I give him 2 points for that. And I think I'm kind of with him, which is, the model was set up to kind of arbitrate dollar flows and risk and apportion the pie on that front. And that's why we're in this, right? Because as costs have increased for good and bad reasons, someone's got to bear that. And ultimately insurance is the construct to kind of apportion kind of who pays for what. Going to the question that Shawn just answered and that you're asking, which is the role of the consumer and trying to understand, how to pick insurance, how to purchase it, and all that kind of stuff. I completely agree. They're not spending any time. Okay. The irony is you will spend more time deciding what car you buy, and all the research that you can do with consumer reports and online and this and that. But when it comes to kind of annual open enrollment and selecting a health plan to get into, it's not even 20 years. I would argue it's decades longer than that, Shawn, frankly, that people just kind of put up the white flag. When I worked at Comcast, we were told more often than not, the average rank and file employee would simply ask their manager during open enrollment in a quick one-on-one, hey, Alyssa, what plan should I sign up for? There's like 7 choices. Just tell me what I pick. And the manager was put in a position to kind of arbitrate that, which is extremely uncomfortable. As we all know, no HR person wants to be deliberating that, let alone kind of a manager. So, we've advocated any plan, selection, decisioning, educational kind of process, because there is no literacy and people don't really see the impacts of plan selection because there's no feedback loop on a year-over-year basis.
Yeah. So I think we can all agree, at Seven Wire, our thesis, our true north is empowering an informed, connected health consumer. How do we give people the information they need, connect them into this decision, connect them into the system to get themselves from sick care to well care? So if we all agree it's time to give consumers information, how do we balance informing them without overwhelming them? And is there such a thing as too much information? Does increased choice, we've seen, to your point, Michael, 7 plans sounds great, but does it lead to increased confusion and complexity? What's the right answer?
Sure. You want me to start?
Go for it.
Yeah. So, I mean, the paradox of choice has been well studied and articulated. And I would say that also applies here to healthcare, whether it's in kind of insurance and plan selection or also in provider selection as well. I will also give you kind of personal experience having been an employee at Comcast and also working with a lot of other jumbo employers, which is most over time have gone away from a fabric of a multitude of regional plans, call it a local HMO, plus some PPOs, plus at least 2 or 3 national plan options to kind of really slimming it down to like one national plan and possibly one local HMO. So at most you've got 2 choices. I think the other thing that I've seen some employers do is really offer choice predicated on monthly deductions for the premiums, such that, you know, as what Comcast HR would have called it, a pay now or pay later plan. Okay, so regardless of what the backbone of the network or the coverage or anything like that, fundamentally people, when they're consuming healthcare as an employee of an employee sponsored health plan, they just want to know, how much are you taking out of my paycheck every 2 weeks? Is it a little or a lot? Do I pay now or do I pay later? And I thought that was an interesting kind of analysis that a lot of third parties, consultants, advisors, and all that kind of stuff, you know, ultimately guided them. And many other jumbos are pretty much doing this as well. So clearly in the days of 6, 7 options, you know, that beget a whole cottage industry of software companies and vendors that were there exclusively to help you pick, right? So whether that's Jellyvision with neat little kind of animations and kind of content to help you kind of be more informed during open enrollment, or that's Pickwell or tools like that, you don't need that if you just fundamentally shrink down the choices, A or B, and here's some quick analysis or quick summation as to why, and then you kind of go from there. So,
Shawn, what do you think about that? What do you think about, you know, the pay now, pay later, you know, this option, that, how does that resonate with you, with the consumers, is what you all are building and find?
Yeah, it resonates quite well. In fact, in conversations with employers that maybe have adopted the pay now, pay later, we've actually talked about a third option, which is what we create, which is pay when you need to. So I actually think that that choice is right with context and with reason. And so Bind, I would say we've constructed a model that actually increases the amount of choice. And we not only increase optionality of coverage, but we also increase your options on when you actually elect coverage. And so we give people the ability to make choices not just once during annual enrollment, but as you go about life and things happen to you and your needs change medically, and therefore your coverage needs are changing, we allow you to change your coverage at that point in time. So it is a new product construct. And that might sound like, whoa, that's a lot of change. That's a lot for people to take on. That's why I said reason to actually look at options. I would say by and large, most people during an annual enrollment cycle, which is just a date picked every year with no real context or reason, other than it's probably not our busy part of the year. If you're a retailer, you don't do it in the fall, you do it in, you know, after the holidays, for example. But most people in that period are not really faced with a lot of medical decisions outside of those that have a continuous need, like, you know, Livongo's caring for. But most people are forced to make a decision on their coverage when they don't really have a reason to make a decision about coverage and they don't really know what they need. Our version of that is, that's a flawed system and a flawed design. Why don't we match coverage and coverage selection and optionality at the point when they actually have a reason to think about coverage, which is when they need care. So we've tried to marry what seems like a lot of optionality to the point when they actually need care and therefore think about coverage, and therefore options don't look bad or they don't look overwhelming because I'm actually in the moment engaged and dealing with an issue, and that's the time I want to think about it. So as long as you're bringing me optionality with context at a time when I have a reason to consider options, options are fine.
Got it. Interesting. You know, talk to us maybe, Shawn, a little bit about, as you think about when trying to introduce a product that's quite radically different in a field as established and complicated as health insurance, how do you get over the hurdle of consumers' preconceived notion of what a health plan should look like, right? Many people there may not be a rhyme or reason for what open enrollment is or when it is, but that's sort of the cadence that consumers are now adjusted to. How do you pull them out of that?
Yeah, I think that is an ongoing challenge, and we certainly haven't achieved the optimal state. I think it starts with going all the way back to 4+ years ago, our first consumer sessions where we were doing firsthand research with them. And if you stopped and said, here's a piece of paper, or tell me in 30 seconds what you would want, or a minute, people don't say they want a deductible. People don't say I want co-insurance. People don't say I want to find out what something costs after the fact. So it's not that you have to break their preconceived notions. You have to break their preconceived notions that nothing's different about my plan lineup this year than the last 10 years, or as Michael said, probably 30 years. That's the problem we face, which is once people see Bind, and I'll give you some stats, once they see it, then we've got a great shot of them selecting Bind, because it is what they would actually design themselves. I like to know how much something costs before I go get it. I like to know my options about whether surgery is right or physical therapy. People like that. They like something they can understand and use. So the preconceived notion of nothing's different about anything, so why would I go bother during annual enrollment to check my options? That's our biggest barrier. And what we see is, I'll give you just an example that COVID brought to life for us. When COVID hit, we immediately said, okay, we need to think about what's our go-forward membership look like. And so we went through and said, okay, by customer, what do we think is going to happen with workforce, reductions, et cetera. And so we write down our forecast 20% on our current membership base, because obviously you're going to have furloughs, et cetera, et cetera. When I looked last week to give an update to the board on Monday, for the customer base that went live with Bind on January 1st of 2020, we are actually up 13+% on enrollment, the number of people that have selected Bind. And you're saying, how could that be possible? Well, it's because when you newly arrive at a company as a new employee, you have to select a benefit. You're not automatically defaulted into what you had before. So that goes to show that when people have a reason to engage, they're fine with options. And then we love it when they engage, because we know we win. Because we know that it's not like these firms are hiring thousands and thousands of people through COVID, but we know we're getting the vast majority of people that are new hires to choose Bind when they look at it against their other options.
Yeah, no, I hear you. I always joke that in healthcare, that we're the worst marketers when instead of calling something, we call it a high deductible instead of a low premium.
Yep.
So we could use some work. Maybe Michael, talk to me a bit about Accolade, one of your portfolio companies. They work with employers to help consumers to navigate in the healthcare landscape. What advantages do you think employers have regarding understanding the health needs of their employees compared to a health plan?
Yep. So I'll answer that by weaving it into the last question. I think where I might have a slightly more realistic view of humans, or a more skeptical and cynical view of humans, is I feel most people, at least in healthcare, are somewhat dumb and lazy. Okay. So while Shawn and his company are offering game-changing, superior products, I think folks aren't inclined to be literate and therefore learn how to make, some of these decisions. And if left to their own devices, they're fundamentally lazy or opt for convenience, which leads me to the solution, therefore, is a trusting hand, a Sherpa, somebody that's your guide, someone who's going to kind of take you through this journey and this process, because it is so episodic. It's not worth your time. You have other things you'd rather do, so on and so forth. So that's why fundamentally for me as an investor, and we subscribe to this point of view at OMERS Ventures, as well as, my prior life, is it has caused the opportunity for a new generation of tech-enabled services, which are really these new advocates, assistants, coaches, guides, mediators, counselors, whatever you want to call them, that come from an independent third-party perspective. So they're aligned with the member, the employee, the consumer, the patient, okay? And they are helping these folks through their healthcare journey, whether it's selecting insurance or figuring out how to kind of consume care. Accolade very much fits into this. You know, it was a journey that was started over a decade ago. So ostensibly, you know, start as outsourced HR benefits and do things that HR practitioners don't want to do, whether it's because of ERISA or other things. And ultimately, because it had fundamentally a trust-based behavioral change model built into what Accolade Health Assistants are doing with members, you know, it ended up being a really compelling way to kind of navigate care and drive cost and quality outcomes on the back end. And that's a thesis that we've had at OMERS Ventures, whether it's for medical kind of consumption, whether it's for pharmaceutical and medication consumption, whether it's financial services and those types of products and services, whether it's for behavioral health. I think you see that in the marketplace kind of borne out, right? What Livongo has done on chronic, what Lyra is doing in behavioral health, what Brightside is doing in financial health, what With Me is doing in PBM and medication, you know, and Accolade's doing in medical. These are all kind of variations on the same theme, which is humans, if left to their own devices and have a natural trusted relationship with another person that they feel is an ally, they will let that person guide them to making the right decisions, again, whether it's insurance or whether it's care. And I think that is a superior model as borne out by all those companies I just mentioned than more of a traditional self-selection, empowered consumerization kind of thesis that I think we've tried for a decade now and we're still trying to break through.
Shawn, any response here? You know, Michael's perspective is, you know, consumers need a Sherpa, that they can't do it alone. What do you think?
I believe that consumers need information. I don't subscribe to the fact that they need a person as Sherpa. And so our belief is that the most important thing in healthcare and to move healthcare forward in the right manner is actually individuals themselves that are able to make decisions that optimize for them what they're looking for. And if they're doing that, the vast majority of the time, those decisions are going to benefit whoever else is part of that risk pool with them. So I don't disagree that people don't need assistance in the form of information and optionality, et cetera. I don't think that they need a layer on top of a navigator, a Sherpa. And I think that's borne through in what we see at Bind in terms of what is happening. So our belief is that from an insurance perspective, we had to start over and design an insurance product that people could actually understand, because they need to feel empowered to make decisions. And once they're empowered to make decisions because they understand their insurance, now you need to empower them with the information to make those decisions. And it's things like when I eliminate deductibles from a plan, when I eliminate coinsurance from a plan, those decisions become like other decisions I make. When I'm able to pick up my phone, pop open the Bind app, search like I do on Google for what I'm dealing with, and Bind shows the options. You know, you can go here or there. You might think about this treatment or that treatment. Don't go to the ED. It's going to cost you $300. You can do a $0 virtual visit right now. Just click a button. When you give them information, they make good decisions. And I'll just, a couple of them, just on the virtual versus ED. When we look at Bind's benchmark performance, and we use Milliman's benchmarking tools, so we look at their typical plan. When we benchmark against that, which they call their moderately managed plan, which is your typical benefit that's offered today, the ED use on a Bind plan is over 30% less than the benchmark. And that's again, it's a form of Sherpa. I just think of it as it's a digital Sherpa delivering information to people in the way they want to consume it, which at this day and age, people want to consume information on their cell phone. So when you create a health plan that allows it to be a mobile first rendering of information, people use it. Another example is, well, just on the use rate, we have 80+% of our households that actually use our app. to get this information. So again, you give them something they understand, they want to then consume information when they need to, and they do. Our delivery rate, so the amount of people having babies on bind against our benchmark, we're at 50+% above benchmark when it comes to how many people on bind have babies. So we have 50% plus increase in the amount of babies that are delivered on bind plans. On the other side of that, the average cost of delivery is about 30% less than benchmark. The reason for that is when we put prices out there and we put a price on something to say you can go to this place and deliver for $700 or this place for $1,700, behind the scenes we're using vast amounts of data to understand what does the performance look like at the $700 versus the $1,700 hospital. We see things like NICU stays and C-section rates. So when you build that into pricing and give them a simple signal they can understand, they make a good choice. They choose the $700 hospital that doesn't rush people to C-section. And so added to that, what we see, now we see more deliveries at lower price points. What's driving lower price points is we have on the C-section rate side, we have about just over 40% lower C-section rate on binds plan versus a benchmark. So you can call it a digital Sherpa if you want.
Shawn, that's indicative of the population that you service?
It's all risk adjusted. So demographics, disease burden, it's all risk adjusted.
Yeah, so I mean, Alyssa, what I would say here, and I would ask Shawn, not knowing the population and the worker type that you guys are servicing, you know, I go to the cable technician who's climbing a pole or rummaging through your basement to kind of wire you up all day long, right? Just doesn't have the time or inclination to get on a mobile app, a web app, to research stuff and all that kind of stuff. A mother with screaming kids at home, right? Who needs to figure out in a moment, do I go here? Do I go there? Am I going to want to log in, look at something? Or if I knew I could pick up the phone or if I could message somebody and get an answer, go here, go there, they're going to do that, right? A warehouse worker, you know, that's driving a truck and all that kind of stuff. And then, you know, I also go to, you know, the partner or spouse where English is not their first language, right? And they're very uncomfortable reading medical literature, whether it's in an app or some other document. And again, if they could get a Spanish speaker, they would much rather engage with that person and be told, do this, don't do that, and all that kind of stuff. That's where I have initially subscribed and bought in and desired your vision of the future. And I've just seen so many real life instances where it falls down. And what I've come to believe is that healthcare is still human centric. It's tech augmenting the humans, but because it's about trust, empathy, compassion, and we're dealing with really sensitive private stuff, just you can do things people to person in a lot kind of more of an enlightened fashion than you can just kind of through the steely kind of coldness of just kind of tech.
And Michael, I think that's an interesting point. You know, talk to me about if we think about, you know, Sam's point of the consumer health advocate, who do consumers trust the most, if not their doctor? Who's the right person for that?
Well, let's knock off the ones they don't trust. Okay, we know they don't trust their insurance company. Okay, that's for sure. We've seen the NPS surveys of traditional carriers time and time again. Okay, they also don't really want to trust their employer, even though the employer is bestowing the coverage upon them. They don't really want their employer to know, I have depression, I have suicidal tendencies, I have this, you know, disease or cancer or something like that. That's not where they want to be. Okay, they would historically trust your primary care physician in an era, you know, when you had a strong relationship with your PCP and you went for annual visits and the PCP knew your whole family and all that kind of stuff. But increasingly, society in the US doesn't have PCP relationships, right? So they're just, whether it's propagated by urgent care, ED, or teleconsults, you know, you don't really see that anymore. And with the growth of industrial health system complexes, where some consumers are sophisticated to know that their PCP got gobbled up by the hospital system that also owns the urgent care and, you know, the outpatient and all that kind of stuff. And they just know they're going to be routed throughout all that stuff. The economics kind of aren't there. So that's why I think the introduction of a new class of third-party intermediaries kind of helping hands, advocates, navigators, whatever you want to call them, that's a response to the fact that there is no trust anywhere in the healthcare system.
So maybe, Shawn, you made the case for sort of the digital advocate, but, in the future, what's the role of humans versus AI and, serving consumers, serving these advocates, helping consumers to navigate decisions? Percentage it out for me. What's going to be tech and what's going to be touch?
Yeah, so I still firmly believe that the person people trust the most is themselves, and the person we'd all benefit the most from being enabled and trusting their judgment is an individual themselves who has to deal with the ramifications of their decisions, good or bad. And I think that from a digital versus human, I had one of those, well, in my bio it said I used to be in the Army. So after the military, I went to business school to try to get educated and learn a new vernacular, et cetera, and I had to change. In one of my courses in business school, a tremendous physician scholar named Richard Bomer, it was one of those moments where you're like, wow, I never thought of that. He said, this is 2006, and he was just going through what it's like, what medical education is like, and then how medical education persists. And what he talked about was really what clinicians are doing when you're in front of them is they're going through a series of probabilistic models on what they've been educated on and what they've seen and experienced. So it's really just, and when you think about what is AI, it's pattern recognition. Like, I've seen this before and I'm going to apply it and I know what's coming next. So that at that moment, he was talking about AI and how it replaces doctors in 2006. And for me, coming from the Army, I was like, wow, this one, I knew he was brilliant already, but this is something I better park. And I think we've seen, whether it's Babylon that's servicing 300,000 as the GP in the NIH. I mean, they are the AI version of a GP, or 98.6, or pick your latest, who just did a great deal with Sam's Club, right? So I think we definitely will trend toward, when it comes to how much on the advocacy side does AI play in helping you understand optionality and what decisions you have to make. I think we get close to 100% as the data that these algorithms can digest and do pattern on gets broader and broader. So I think that approaches 100%. I don't think we'll ever lose the fact of you still are going to want to go validate probably what they said with the clinician. And I think from an advocacy perspective, I still believe that the best path forward is to enable people to be their own advocates. And I believe that if people would just, when they're at their doctor's office and someone tells them you have something and here's what you need to do next, I think it would be tremendous in this country if people just asked them a couple of questions, like, what happens if I don't do anything? What other options do I have? Is there any risk for me doing what you just told me I needed to do? So just that, I mean, advocacy can be that simple. Like, if we had a public campaign on all the news stations about just ask those 3 questions of your doctor, I think we'd be in a much different spot 10 years from now as well. And I want to make sure I am able to go back to Michael's previous response about bind. So I did say it is definitely risk adjusted. Our customer base spans, an 80-person book publisher in Minneapolis to very, very large customers. And just to give you a specific example on, the distribution worker that you mentioned, or the person climbing the poles to put up cable line, I can actually give you 2 very specific examples of why those people are still doing fantasy football probably on their phone. And I don't believe that people want to pick up the phone and call. They want to pick up the phone and search. That's just where we're at. And in both of those instances, both of those clients, one, a large retailer, expanded where they offer bind for next year because of feedback from, I offered in one state, I have a distribution center close to the border, and all the people on the other side couldn't get access to bind. So HR did a great thing, right? Which is listen to what people want and offer now bind to that additional state, and it's distribution workers. And then the other, on telecom, we have a very large telecom who puts up a lot of cable. Based on the feedback they got from their employees and bind's performance in our first year, they have now decided they've adjusted binds, what people have to pay for bind, on the order of 50 to 90% across weekly contributions. So I hear you on when you think about what I'm saying, and I talk about digital and people picking up a phone, you automatically think this is for young and healthy. This is for tech companies. This is for people. I mean, we just design what people want, which is give me something I can understand and pick up my phone and use and get clear answers. Like, just give me that. That's all I want. And that's anybody. I don't care who you are, young, old, working at a distribution center, or, a VC. Sure.
No, I think that, that's interesting, Shawn, especially, as you think about digital front door. You mentioned Babylon. They invested in one of our companies, Higgy, but really it's, the way we think about it is less mobile and more meet consumers where they are, wherever you may be. And Higgy still has stations, because those, you have to find people, right, to get access to their health, their information, engage with them in the places that they are. And Michael, I'm curious from your perspective, as we think about the, percentage it out for me, tech versus touch, what does that look like in your world? And maybe, and that's on some investment areas that you think are most interesting in this space.
As I said, tech augments the human in healthcare. I finally believe in that. I think it allows the human to do the things in the last mile that only the human is superior in doing. But a lot of the upfront stuff can really be done by tech. That could be all the intake stuff, which we hate doing, whether on the provider side or on the patient side. That could be all the symptom checking and triaging. It could be all the benefits validation kind of stuff as well. And I think where it gets super powerful is that it really allows the human to have superpowers, so they know that the next best action for Alyssa or Shawn as a patient should be X, as opposed to let me ask 2 or 3 questions, let me get into my little spiel with them and kind of figure it out. Like, the machine is starting to kind of guide you further and further down the path, so that you can really focus on the higher value added discussion and kind of decision points. And ultimately, I subscribe to the point of view that outside of chronic and certain things, most of healthcare is about behavioral change, right? And behavioral change is just a bunch of science and nudges and pushes and carrots and sticks and all that kind of stuff. It has been proven to be done extremely well by humans. It can also be done by tech, but that's why I'm kind of like, interventions, behavior change, if that's really what the human is there to do, and tech is telling them kind of what to do, I think it's a good spot to kind of be in.
Absolutely. I'm a tech and touch believer as well. So not to show my cards here, but let's do this. We have, I think, just under 15 minutes left. I do want to give the audience opportunities to ask questions of this group. If not, I can continue to ask more in this debate. It's been super fascinating to hear both of your perspectives. Perhaps I think Stephanie has been fielding some of those questions. And I think those on the line, if you do have questions, please do send them into the chat.
Okay, great. Well, I've got a question for Shawn, actually. I imagine you have a lot of competitors in this space. What was the first sort of major collaboration milestone your company did that you feel really kind of solidified your position in the market?
Sure. So I think whenever you're starting from scratch, nearly everything seems like a big milestone. So certainly the first sale that you make is a major milestone, because that's what you were looking for. That's what your capital partners are looking for, which is milestone 1 is prove to me you've got something someone will actually pay money for. So that in terms of a company milestone was large. What I will say is that I actually think what, from a milestone perspective, is most meaningful to myself and the people that work at Bind have nothing to do with selling or adding a logo. It's actually about when we see results that we're actually impacting people for the better, that are climbing telephone poles, that are working in a distribution center that's 100 degrees in the middle of a Texas summer. And knowing that we're saving them out of every paycheck knowing that we're saving them when they have to go access care. So at Bind, less than 1% of people actually hit their out-of-pocket max. At Bind, when we look at how much people spend out of pocket, it's just over $400 on an industry average of about $900. So knowing the impact we're making to people on a financial level, knowing that when they are, they suffer from something, that they have certainty about how much things are going to cost and what their options are, and they don't have to worry about that. That's what's meaningful. And I think just last week, we probably had one of our most impactful milestones, which is we had one of our customers, for their employees that make less than $50,000 a year, for next year, because of what they've seen Bind do for their employee base on a health as well as financial health perspective, they're actually putting forth an ability for the people that make less than $50,000 at that firm, and there are about 30,000 of them. They actually can get Bind for $0 premium. So from an impact and milestone perspective, those are the things that we as a firm, we as a people, that's why we get up to do this, is because we know the impact we can make for the people we get to serve. So it's really not about logos, et cetera. It's really about knowing we are making a difference for all sorts of Americans.
But let's talk
Is that another question?
Yeah,
No, you go.
I want to talk a bit about the role of government. So there was a question that came in on, what happens to these models, either self-directed or the Sherpa-led, if Medicare for All becomes a reality. And maybe what role do you both see the government playing as we think about redesigning insurance of the future?
Sure, I'm happy. Yeah, I'm happy to start. I think historically, you could say that government has really been a rate setter. Like they're really kind of the arbiter of price because of CMS and all that. As much as they have strived to kind of focus on quality, on outcomes, on access, at the end of the day, the blunt instrument that they wield and kind of lead with is really on reimbursement and rate setting and all that. So I still see that to be the case. I think some of the mandates on access and coverage and all that kind of stuff, I mean, those are the things that are most politically fraught right now. I've long stopped trying to prognosticate whether or not Medicare for All or some other kind of nationalized healthcare system will come to the U.S. I think in probably all of our professional careers here on the panel, it's not going to happen, would be my current guess. So therefore, my investment thesis does not contemplate Medicare for All or variation of that kind of coming. I think there's this kind of the political system and then kind of the various constituents today, they're kind of okay with an employer-driven healthcare system, whether it's health plans, whether it's providers, whether it's pharma, whether it's, everybody else, frankly. I think they've just kind of figured out a status quo on that front. So we're investing under that assumption and trying to figure out how to optimize and make it better.
Shawn, any feedback as well?
Yeah, so I think what's happened with COVID, I think really exposes the challenge that government has between regulating and actually designing. And I'll just give a couple examples that I think are actually quite actionable by the government, and maybe say where they've maybe skewed too far, which is, I don't think we want the government designing insurance products. We want them regulating the insurance products that other people design. And I think COVID actually highlighted that quite well, the challenges that we have in current, what they've done. So COVID hits and we say, oh my goodness, you can't go get a COVID test with 100% coverage because it's in the deductible layer. Because that's what the government designed the product to be. You can only allow certain things to be covered 100% in the deductible layer. So that right there is saying we probably need to get them out of insurance design and back into regulation, because it just proved that it's not a good spot for them to be in. Related to that, they made the change on the coverage in the middle of the coverage policy year. And heretofore, they've said you can only change your coverage if you basically have a baby or you get married or divorced. And we know that, I already said, when you pick a spot in time, that maybe is when a couple people are dealing with something. Why shouldn't coverage be allowed to change as our lives change? It's not that all of our medical needs all of a sudden happen in November and December. So that right there is another example of why would you write rules and design products that that are locked in at one point in the year? That's the second thing. The third thing that COVID showed was all of a sudden we have millions and millions of people out of work. And we've tied coverage to their work. And oh, by the way, we've also tied something that can move with them, a health savings account, a great financial development. That's only allowed to be paired with a product type that has a deductible of a certain level. So a product like Bind without a deductible, we can't take advantage of an amazing financial instrument called a health savings account. Why? So there are several things I think that COVID actually shows clearly that there is easily actionable items that the government can take now to move themselves out of a product designer seat to a regulator seat that I hope they actually consider doing rather soon.
Yeah. All right. Well, let's jump to another one of the questions. Maybe talk just a bit, as we stay on the government topic, but ACA and obviously how integral it has been in so many areas of healthcare and the transformative change that it brought. How do you see ACA's role as it relates specifically to the world of redesigning insurance?
I mean, I'm with Shawn on this one of the role of government, designer versus regulator. I also think we need a very vibrant individual market, right? It's kind of like the backwaters historically. The major commercial plans kind of did it not on their own volition, but they kind of felt they were kind of forced into it. If anything, I think there's more innovation coming out of startup land to kind of go after the individual market. And hopefully we'll kind of see more of that. I think the same parallel to the individual market is the MA kind of market as well, that is now kind of a principal domain for venture investors to kind of try to innovate in as well. So hopefully there's more vibrancy in MA, there's more vibrancy in individual, and that just kind of raises the bar kind of throughout the rest of the insurance landscape.
Yep. There's a question from the group. Shawn, you mentioned an 80 employee company that's a customer. Is that the low end of size that you service? Kind of just maybe for the audience here, what's your average size and employer?
Sure. So I'm happy to announce that just last week we were approved for a fully insured group product for companies that have 51 or more employees in the state of Florida. That was the first of several that we have filed that have been approved. So, stay tuned. We'll have more states where we offer 51 plus fully insured group coverage. On the self-insured basis, the 80-person company I mentioned was a self-insured company. Depending on different geographies, et cetera, 80 is probably about the low point most consultants would recommend people get down to self-insure. So our typical client base is north of 125, 150 on a self-funded basis. And we go up to companies that have, 400,000 employees. So it's really across the self-insured space, the self-funded groups, it's usually down to about 150 is where we see the clustering kind of stop. But on the fully insured side, 51 plus is considered a large group in Florida, for example.
Great. What do you guys think about wellness apps? The integration of the Fitbits, step incentives. Do employees use them? Are there benefits to them? It's a question someone has.
I would say with mixed results. I think certain populations gravitate to them. I think it's also been shown that people who are likely to go out and purchase them on their own without the employer providing it and or kind of live that lifestyle, this is just kind of self-serving for them. So are you really catching the population that could actually most benefit from it? Hard to say. I think the other thing with wellness as a category, it's just become a point solution, like every other point solution that employers are bestowing upon their dependent base. And because it's proliferated to such degree, you're not getting the awareness, the engagement, and the utilization of any of these programs as you used to, right? Which also speaks to the need for some of these navigators and overlay kind of services that can do a better job of marshaling the message and really kind of doing campaign propagation into some of these particular programs. So I kind of put all of wellness into that bucket.
And I'll just say, I'll let the product speak for itself and answer that, which is on the standard bind plan offering, there is no wellness solution.
So talk a little bit about price transparency. Shawn, you mentioned that you've done a lot of work here. You can actually, easily show the consumer the difference between a $700 and $1,700 visit. That's historically been very challenging for folks. So how are you doing it at Bind? And then Michael, maybe you speak a bit more broadly on the industry. And I think with that may actually be our last question because we are at time.
Sure. And again, I'm just going to go back to, in order to deliver what people want, which is I want to use my phone and get answers on one of my options and one of my prices. You can't do that with certainty when you have a deductible and co-insurance layer, because everything is then adjudicated after you've been somewhere and they tell you what you need and then they document it in their system, and then a coder makes sure that they've actually put codes against it to get paid for that optimize revenue. And then after you're home for a while, then you get bills. So because of the insurance design that really proliferates today, you really can't get a price with certainty. So you have to eliminate the things that don't allow you to do that. And you have to turn it into essentially a model where you just show a price, which the industry lingo would be a copay. Everything just needs a copay. In order to do that, you have to do a lot of analysis and math and apply probability and statistics to come up with, okay, what should the price be for that service at that place? So it is doable, and we've shown that you can do it. It just is not what most companies are doing, because they have a different insurance design that is really stood upon the cost sharing mechanisms known as deductibles and co-insurance. And again, when you have cost sharing mechanisms that look like that, you can't possibly give someone any certainty about what they're going to pay. One, because I can't tell you, because I don't know what the doctor's going to do to you. So until they tell me what they did to you, I can't give you a price. And then once they tell me what you did to me, then I have to look at where you're at in your deductible. I have to apply your co-insurance layer, et cetera. So that, going back to, we get what we designed for. We designed a system where you call, if you have a need, make an appointment, come in, I'll tell you what you need, and I'll send you on your way, and then I'll bill you for it. That's what we designed, that's what we built, and that's what we have. Bind said, we're not going to get far with that. We've got to enable consumers with information. In order to do that, you have to change the model, change the insurance, and give people prices with certainty. I told you you're going to pay $20 to see that doctor. Guess what? When you get a bill, it's $20.
So I would answer it slightly differently, which is, if you look at the 10-year history of price transparency and cost transparency tools, I think you can almost say it's been an unmitigated disaster, right? As evidenced by some of the companies that are in the business, kind of, where they've kind of fallen on tough times. The whole thesis of consumer empowerment and information and giving them the ability to look at cost, quality, and convenience, meaning kind of proximity, location, hours of operation, all that kind of stuff. People were still stymied with that process. And even with that tool, engagement never got to where it needed to be. And, the ROI on the investments in this tool category never came close to what, the vendors were pitching. At Accolade, we saw provider selection is right there, like number 1, number 2, number 3, in terms of top inquiries from members for assistant from their Accolade health assistant. Okay. And it wasn't like, give me a bunch of information and I'll go decide. It was like, literally, pick it for me. Okay. Do it for me. That's kind of where society has gone on so many levels. And if anything, it was like, I want convenience first and foremost, right? Like close to work, close to home, the right hours and all that kind of stuff. You know, I care about quality. Don't send me to a bad doc who's going to do something bad to me. And then cost is the last thing they cared about, even though it was under the context of a transparency tool, right? So that's why, you know, it hasn't quite worked out. I think you've also seen employers kind of respond to this with the rise of centers of excellence, right? To the point where for certain procedures, certain surgical kind of interactions, we're going to tell you where you're going to go. And even if we got to fly you, send you here, put you up and all that kind of stuff, like we're not going to give you the choice to kind of make. So I go back to the original premise on a lot of this discussion is, are we truly literate? Are we truly kind of motivated to make decisions on our own? You know, I think some people are. I would still say the vast majority of people in America are not, you know, whether it's for a variety of characteristics. And that's why, you know, we really haven't moved the ball forward on a lot of this consumerization thesis that we had all hoped.
Well, with that, I think, you know, Michael, Shawn, I want to thank you both for the time today. It was quite enlightening. You know, I think we can all here agree that there's a lot of room to run on redesigning insurance, and that we all believe in empowering consumers to be stewards of their own health. And so with that, I thank you both. I thank our audience for tuning in, for staying a couple minutes over, and I will turn it back over to the Med City folks.